Hey everyone, we've got another heart today. This is number 1468 in our collection, and the heart would have sat roughly in the chest like this. You can see that we've also got the trachea and the lungs attached to this specimen. Anterior surface would be coming out towards the screen, posterior surface towards the turntable, inferior legs down here, superior head up here, left over here, right over here. But let's start as we always do, which is by trying to find what at least externally appears to be the morphologic right atrial appendage. And here we find an appendage that externally looks pyramidal in shape, broad-based or triangular, consistent with the morphologic right atrial appendage. So why don't we go ahead and open up the heart there. And when we do, we find that there are in fact pectinate muscles that spill outside the confines of the appendage, consistent with the morphologic right atrium. And you can see the extent of the pectinate muscles more here as well. We also find that the superior caval vein does enter the right atrium, and here's the superior caval vein entering into the superior aspect of the right atrium. Now, when we open up this right atrium some more, we notice a few things. There's a pretty prominent eustachian valve here. Okay, so a very large eustachian valve, a structure that we often note on echo if it is this large. And then we also find that there, in fact, does appear to be an atrial septal defect in the oval fossa. So an oval fossa type atrial septal defect, and we'll try to pass the probe to it and see if we do actually get through it. And when we go to the left atrium, we do find the probe coming out. So we do have an oval fossa type atrial septal defect. And then of course, once again, this prominent eustachian valve. Now we also find the mouth of the coronary sinus that's draining into the right-sided atrium. Right, and that is right here. All right, so there is the mouth of the coronary sinus. And the mouth of the coronary sinus, the tendon of Todaro, and the right-sided AV junction form the triangle of Koch, and at its apex is where we would expect the atrioventricular node to sit. So we'd expect the AV node in this heart to live right about here. Now, as we turn our attention to the right atrioventricular junction, we do find what appears to be a 3-leaflet atrioventricular valve, 1, 2, 3. And we do find that this valve does have direct septal connections, consistent with the morphologic tricuspid valve. When we look at this ventricle itself, there does appear to be coarse trabeculations, and there is the septomarginal trabeculation, all consistent with the morphologic right ventricle. Now, if you look carefully as we look down, there does appear to be a hole here, or a ventricular septal defect, and the probe does pass through it. So you can see it's kind of in the central area of this heart. Let's see if the probe in fact goes through over to the left, and it does. So there is a central ventricular septal defect, and it does appear that the tricuspid valve does go through this defect. And it does look like here on this side, on the left side, the mitral valve goes through it, so there does appear to be tricuspid mitral continuity through this defect. So this is a central perimembranous ventricular septal defect. So once again, from the right side, you find it right here, nestled behind the tricuspid valve in the center of the heart. And the tricuspid valve and mitral valve do have continuity through this defect, consistent with a perimembranous defect. When we return to the right side and look at the right ventricular outflow tract, we find a semilunar or ventricular arterial valve, and this has 3 leaflets, 1, 2, 3, no coronaries arising from it, consistent with a pulmonary valve. And once again, the pulmonary valve is entirely supported by muscle here. And just to point out, as we have been doing, is that the semilunar or ventricular arterial valves have these triangles of muscle interposed between the fibrous valvar leaflets. All right, so the true annulus of these valves is actually this crown-shaped and not necessarily this round or oval-shaped annulus that we kind of develop by echo or CT or some of our imaging. That's not to say that this construct isn't helpful, particularly for surgical planning, but its true annulus is truly not round or oval. It's actually this crown shape. Nonetheless, here's the pulmonary trunk. We see that the branched pulmonary arteries are in fact arising from the pulmonary trunk. And when we look at it, here's the left pulmonary artery coming here. Here's the pulmonary trunk. Here's the left pulmonary artery. And then here we actually find the arterial duct, which then leads into the aorta here. Okay, so there is a patent arterial duct as well, and the probe is passing through that. Now, if we go to the posterior aspect of the heart, here's the posterior aspect of the heart. Let's go ahead and open up this atrial chamber here. We do find that there is a atrium here that's smooth-walled, consistent with a morphologic left atrium. Here's the mouth of the left atrial appendage. We put our probe through it, and we see here is the left atrial appendage externally as well. All the pectinate muscles are confined within this appendage itself, consistent with a morphologic left atrium. And here we can see the pulmonary veins coming back to the superior aspect, the posterosuperior aspect of the left atrium. And here is that oval fossa atrial septal defect that we already appreciated from the right side as well. Then on the left atrioventricular junction, we find that there is a 2-leaflet atrioventricular valve, and that this valve does not have any direct septal connections, consistent with a morphologic mitral valve. So here's the mitral valve, and when we look at the ventricle it leads into, it has pretty fine crisscross trabeculations. It's relatively smooth, consistent with a morphologic left ventricle. And then we find the ventricular septal defect here. Once again, this is a central perimembranous defect. You can see that the mitral valve does course through it, leading to some fibrous continuity with the tricuspid valve. And then the left ventricular outflow tract is back here, and here is the ascending aorta. Here's the transverse arch here, and then here is the descending aorta, and once again here's the patent arterial duct, and here's the pulmonary trunk, and once again we can pass a probe through this and have it exit from the aorta here. So in this heart, we've got usual atrial arrangement. We've got a oval fossa type atrial septal defect. We have a prominent eustachian valve. We have concordant atrioventricular connections. We have right-handed ventricular topology. There is a central perimembranous ventricular septal defect. There are concordant ventriculo-arterial connections, and there's a patent arterial duct.